The healthcare system in our country was built as a one-size-fits-all, and that size is for big cities.
They built a system that works for urban spaces. But then when you have to factor in all of the challenges that we experience here in rural areas like the North Country, it's kind of like wearing clothes that don't fit.
Healthcare researcher Allie Coates argues that leaves rural communities underserved and patching together answers. A special conversation on rural healthcare on today's Story of the Day.
Support for Story of the Day comes from Long Run Wealth, an SEC-registered investment advisor in Lake Placid, providing comprehensive wealth management, retirement, and financial planning solutions. LongRunWealth.com. And from SciTech Business Solutions, training and consulting services to help businesses grow. More information at citec.org.
Hey, I'm David Summerstein. It's Wednesday, October 4th. Let's get right to my conversation with Allie Coates. She teaches research to physician assistants at Clarkson University in Potsdam, and she's getting her PhD at the University of Ottawa. She's also vice president of the New York State Association for Rural Health.
If you think about how healthcare is paid for right now, we pay for services rendered, right? So if you have a lot of patients, then you're getting a lot of money because there's a lot of people going through the system. But in these smaller centers, we don't have as many patients going through. We still have a lot of fixed costs associated with delivering care that we can't offset with just having more patients or just doing things more efficiently. So it kind of changes the model. And a lot of the things that we think about as being healthcare improvements rest on increasing efficiency. That's not necessarily the problem that we have in rural spaces.
So how could it be different? I mean, imagine for us a different world of a healthcare system designed for a rural area like the North Country.
Oh, I wish that I could just design this. That's a tough question that you're asking me to do. I think what would be great is if we could loosen up these regulations in such a way that allows rural areas to maximize the use of the assets that they have. So we've got a lot of really cool things about rural spaces. Like we are innovators, right? We do innovation all the time in our regular lives because environmental pressures and societal pressures make us do things differently. And so if we were able to innovate and if we were able to do things in a way that uses our available resources, then I think that we could produce better results. For example, in Pennsylvania recently, they changed the way that they pay hospitals, rural hospitals. Certain hospitals were allowed to get global budgets, meaning they got a certain amount of money per year, regardless of how many patients that they saw. So they weren't getting paid for each person who came through the door, who had procedures or had inpatient stays. They got a chunk of money and they got to spend it the way that they felt was appropriate for their region. I think that that would be cool, right? Like to be able to take a pot of money that is meant to serve your population and to do it in a way that works for your population.
We're doing this series on healthcare in the North Country. And, one of the issues that really comes up again and again and again is not enough, really, that there's not enough patients, like you already said, that there's not enough resources, that there's not enough clinics. And you've written that rural healthcare systems are too often defined as a system of deficit, of lack. Why do you see that as a problem? I mean, isn't it just the reality that we have fewer people and fewer resources?
It is the reality. But when we become fixated on it, when we become fixated on this idea of rural not having as much, not having enough, we stop thinking about the ways that we could use what we do have. And I feel like we should be building up our systems and we should be appreciating all of the great things that exist in rural spaces and using those to make our health better.
Let's talk about a particular way that, rural healthcare has adapted that has become huge in the North Country and a big concern that our listeners and our audience told us in surveys and texting club that we have, and that's regionalization, that most smaller hospitals have become affiliated with larger hospitals in the big cities. And this has been a really big research focus for you. How is regionalization working where we go for higher level care to bigger cities where there are bigger hospitals?
To be honest, there's not a lot of research out there on the outcomes of these types of affiliations. There is some new research that suggests that we see an improvement in quality outcomes. We have other research that shows that we have a decline in some of the outcomes. So it's pretty mixed. My probably wishy-washy answer is it really depends. I think what we're going to see over time is that the impact of the partnership or of the network is going to depend on the quality of the partner. One of the things that we see in other parts of the country is these huge national chains that are scooping up little hospitals, and they're just here's how you do things now. We're your new masters. Whereas I think what we've seen here in the North Country is affiliation with more local networks. So we have, one half of our region that's affiliated mostly with University of Vermont. And that model, they seem to have a very good understanding and a very good appreciation for the various local regions that are part of their network. On the other side of our county, we've got an affiliation with Rochester Regional, and they're further away. And it's a bit of a newer partnership, so it'll be interesting to see how that plays out. But I think the important thing with any partnership is that you have to design your system so that you have care pathways, right? You want to have really tight connections so that when there's something that has to go from the rural space to the urban space or to the other larger hospital, that you have the way to do that.
It sounds like, a lot of what you're saying is that the mergers happened for financial reasons without the sort of research before to figure out what is the most effective way to do it. And now we're trying to figure out what the most, whether it's working.
Yeah, so I can't speak to the exact reasons why each particular hospital joined a network. But I do know that for many, many years, rural hospitals have been facing, an existential financial threat. They have been closing at alarming rates, climbing rates still. Like we're still seeing more and more hospital closures every single year. They've been paring back their services. We're now seeing way more hospitals become critical access hospitals because they changed the rules now about who can do that. And that offers a little bit of a lifeline to struggling rural hospitals. But I think in a lot of cases, these affiliations happen because people feel like the administrators feel like there isn't a choice. They want to serve their communities and they can do it with a little help.
What worries you most about the trajectory of rural healthcare right now?
Honestly, I worry about our rural communities getting left behind. I worry about our communities losing local resources because I think that we risk hollowing out these areas where people live and work and play and taking away the things that allow them to stay healthfully in their own communities. So if a hospital closes, the community really feels that. When a hospital merges, there are potentially some losses of jobs as some jobs are moved to, the system, and that impacts communities. The loss of healthcare jobs, those are often some of the highest paying jobs in the region. And so the towns lose that tax base. That means their social services, their schools, all of these things that are paid by taxes get impacted, and it becomes harder to live here. We don't have good answers, although there are a lot of policy mechanisms that we advocate for over and over. Can we do loan repayment programs? Can we provide incentives for reimbursement in rural areas? Can we build new residency programs that bring people in at the time of their lives that they're ready to put down roots? Because that has been shown to keep people in a region. I think this is what gives me the most hope, is thinking about what are these things that we can do that can make healthcare better in rural areas.
Allie Coates is a PhD candidate in health systems management at the University of Ottawa. She teaches at Clarkson University and is also vice president of the New York State Association for Rural Health. She lives in Potsdam. We have more news all the time on our website, ncpr.org. Music today by Caitlin Scholl of Lake Placid. I'm David Summerstein, North Country Public Radio.